Most emergency response calls within our district will be requests for medical assistance, ranging from minor incidents to cardiac arrest. Some of these calls may also involve trauma. This presentation will cover the expectations for EMS providers when responding to trauma caused by vehicle accidents. We'll cover several key considerations for EMS providers during these types of incidents throughout this presentation. For every dispatched emergency response, there are corresponding call notes. These notes will vary depending on the quality of information provided by the person reporting, or PR, for that incident. These dispatch notes provide the best information for responders to base operational decisions and avoid being caught off guard. We will review two different sets of notes highlighting the key differences between what may appear serious and what is actually critical. There are two different calls which we will review. There is a significant amount of information to sort through, so we will break it down step by step. The first two lines on the notes have the address and the trauma catchment area for this call. This information can be helpful if responders are unfamiliar with the area. However, the address can be found more easily elsewhere, and the trauma catchment is not applicable since we are outside the Las Vegas area. The line after the first two provides the initial note entered by the call taker, describing the incident as a black GMC versus house. Below that, the letters UNKINJS indicates unknown injuries. Responders can base initial resource decision on these two pieces of information. There are a few key considerations to take with these notes that can help determine the severity of the call. First, responders may sometimes see the note duplicate call appended to the incident. This means multiple callers are reporting the same incident, or there are multiple calls for the incident. This can indicate that the incident is evolving or confirm its legitimacy. If you examine these notes, you will not see that entry, which indicates only one person has called to report the incident. This suggests the call may not be as severe as initially indicated. Second, there's limited information on the patient or the extent of the injuries. This could be due to a single caller, limiting the information obtainable. This call could have also been transferred directly from our law enforcement partners, potentially leading to communication issues between dispatch offices and resulting in misinformation or a lack of information. In either scenario, there is no specific information regarding patient condition, number of patients, or other factors that would indicate a severe incident. Differently within Las Vegas than it does for our valley. Our officers are proficient at providing information and responding to calls when requested. Often, we will not see Metro is pending for our calls. The key takeaway is that Metro is still pending, again indicating the call has been going on for a while. Using this information, initials and responders can determine that the resources initially dispatched for this call will likely be sufficient to handle the emergency response. Another consideration is the extent of the damage to the building and whether additional resources will need to be dispatched. This decision will be made by the officer or acting officer in charge of the call. They can also request the American Red Cross or ARC if residents are displaced due to damage and require temporary shelter because their residence is uninhabitable. If a commercial building at this address is involved and appears compromised, Public Works or the building department can be requested. The final important detail in the notes for responders is the type of transport unit responding and its originating location. Units starting with 200 or 800 are intermediate life support or ILS units, which respond to all alpha calls and certain Bravo calls. 300 or 900 units are advanced life support or ALS units, and 400 have a critical care transportation paramedic or CCT paramedic on board. This information will be helpful to initial EMS responders to identify the incoming unit type and determine if a different unit type needs to be requested. Medic West positions units close to the valley, typically at Cheyenne and Nellis or Cheyenne and Pecos. These units can reach the valley within 45 to 55 minutes, depending on the incident's location. So this is another example of dispatch notes for a vehicle accident. While some elements are similar to the previous example, key differences help responders determine this call is critical. The notes with the greatest impact on this call have been outlined in red for easier comprehension. The first note in this call describes the incident for which units are being dispatched. Vehicle versus motorcycle, or MC, should immediately raise responders' index of suspicion, as any accident involving a motorcycle could be critical. The next note is a general entry for the call that the computer assisted dispatch, or CAD system, inputs based on information provided by the PR. In this instance, it states a 35-year-old male is conscious of breathing with a chief complaint of a traffic accident. These are general notes created by the system, not manually input by a dispatcher, and should be used with extreme caution. Further exploration of the notes will provide more clarification. As with the previous example, an ALS unit is assigned to the call and responding from a northeast hosting location. Cheyenne and Iroquois is near the community college campus at Cheyenne and Pecos. The next note was manually entered by a dispatcher. Manually entered notes are typically in all caps, indicating they were typed by dispatch. These two notes now state that a 16-year-old male is conscious and breathing, or C/B, and that Metro is en route. In town, this helps responders determine that the call may be more serious, as Metro can choose which calls they respond to. Since units are responding to a motor vehicle accident, or MVA, they should already suspect multiple patients. This new note could indicate that the presence of both a 35-year-old and 16-year-old patient, suggesting that additional units may be needed to handle the call. The next section of notes is again computer generated, providing general information. The issue is that these notes now suggest there is a 20-year-old male patient. Again, these are general system generated notes, should be used with caution, as they may not reflect the true nature of the incident. They also mention a 16-year-old male patient, which does support the note entered by dispatch. This general note may be used because it supports the note entered by dispatch, whereas the other two generated notes do not. The next note, duplicate call appended to incident, indicates that this call could be critical. Two consecutive instances of this note suggest multiple callers are reporting the same incident simultaneously. While this note may appear in any call, the key difference here is the multiple calls were made within a short time frame. The calls were made within seconds of each other, indicating multiple witnesses nearby or on scene reporting the same incident. The final part of the notes also indicates that this call is critical. Specific information about the call is provided within the last few notes. This includes the type of vehicle involved, the rider's position, the PR's name, and specific information regarding the patient's condition. In contrast to the previous example, this demonstrates how more specific details from the notes can indicate a more critical call, helping your responders make informed decisions. After reviewing the notes and ensuring they are up to date with the most current information, EMS responders will need to consider if additional resources are required, especially if they are officers. The expectation for our station is that the officer will prioritize ordering additional resources while en route to the scene. If no officer is responding, the member who first acknowledged the call on the radio will communicate with dispatch while en route to the station. If that member or officer prefers not to be the primary communicator, the other responding members will determine who will act as the officer in charge of radio communication. The first priority for EMS providers is patient care, regardless of rank. However, if the officer and/or member is the highest level of care and is the only person comfortable using the radio, patient care may need to be delegated to other EMS providers until additional units arrive. This decision should be made on the patient's status upon arrival at scene and the capability of the crew members on the unit. If no member is comfortable using the radio or does not stand the incident command system, or ICS structure, priority goes to patient care and controlling the scene until another unit arrives to assume control of the incident. Now that we understand how the notes can help responders determine a call's legitimacy and who will manage the incident, we will cover the overall expectations for EMS responders when responding to a vehicle accident. This flowchart provides an overview of expectations, and we will cover each part in depth. After ensuring scene safety and implementing body substance isolation or BSI precautions, the initial priority for EMS responders is to determine the number of patients involved. This information is crucial for both EMS providers and the designated incident commander, or IC. Furthermore, EMS responders should consider establishing command if 3 fire department units are responding. If an early arriving EMS provider establishes command, they may need to simultaneously manage the incident and provide patient care if there are insufficient providers initially. However, if there are adequate providers and a member is confident in their ability to deliver quality patient care, they may opt to focus solely on incident management. Depending on the number of patients that is reported by triage will dictate the next steps taken by EMS providers. The events that take place if there is a single patient versus multiple patients in an incident vary greatly for both resource allocation and responders' priorities. We will first cover what is expected if there is a single patient. Once it has been determined that there is one patient, EMS providers can shift their attention to providing care for them. The first step, as with any patient, is to perform a quality assessment. Since these incidents are traumatic in nature most often, we will go in depth on what is expected of our EMS providers in performing a trauma assessment and then determining the most appropriate hospital per the Trauma Field Triage Criteria, or the TFTC. The Southern Nevada Health District, or SNHD, is the governing body for all EMS providers that are licensed within Clark County. They provide protocols for EMS personnel, which are similar to standing orders given by a doctor to nurses within hospitals. The protocol here is a general adult trauma assessment, which provides a flowchart for EMS providers on steps to perform a trauma assessment for adult patient. A note on adult patients is an adult is defined medically as a male that has developed body hair or female that has developed breast tissue per the verbiage in the foreword of the protocol manual. The reason this needs to be clarified on what a pediatric versus adult patient is due to providers attempting to treat a 12 to 13-year-old patient as a pediatric, where they should clearly be treated as adults medicinally. Going through the protocol, providers should consider cervical stabilization when possible and next determine the Glasgow Coma Scale, or GCS. GCS is determined by EVM 456, or eye opening with the highest score of 4, verbal response with the highest score of 5, and motor response with the highest score of 6. Providers will combine all three to determine what the patient's GCS score is. The number to be mindful here is 8. If the GCS is equal to or greater than 8, the patient can be placed on supplemental oxygen to keep their oxygen saturation, or SpO2, greater than 94%. If it is less than 8, ventilation management via BVM should be initiated to again maintain the SpO2 over 94%. The next box in the flow chart is for the provider to determine if the patient has a radial pulse. In either situation, intravascular or IV access should be obtained and fluid should be administered if the pulse is absent. Before we finish covering the flow chart, providers do not need to follow this flow chart step by step in the exact sequence. The flow chart is a guide that gives recommendations to providers on steps that should be accomplished. If you arrive on scene with your one patient and they are not breathing or their airways obstructed, you may take care of those issues prior to applying a cervical collar, or they can be done simultaneously. If you determine your patient is not breathing and has no radial pulse, you may want to check if there's a carotid pulse to confirm if they are in cardiac arrest and begin resuscitation efforts before any other part of the trauma assessment is completed. The assessment flowchart is again a guide to assist providers in steps that should or can be done for a general trauma assessment, not a catch-all for every trauma call. Use good judgment to determine what is the correct treatment for your patient. You may be working out of multiple protocols at the same time to provide proper and adequate care for your patient. The rest of the protocol directs providers on performing a secondary assessment and then providing some alternative considerations and treatment for those, such as applying an occlusive dressing for a suspected chest wound, or raising the head of the bed to 30 degrees and maintaining an end tidal, or ETCO2, of 35. It also refers providers to the appropriate protocol to treat certain conditions such as a suspected tension pneumothorax, which is referred to the needle decompression protocol. As with all traumatic injuries, pain management should be considered to assist in recovery and care for these patients. The picture on the right is the second part of the protocol that mentions what history should be obtained by the EMS provider, associated signs and symptoms, and other pertinent life-threatening differentials that providers should consider during their assessment. There are extra pieces of information that are called pearls. These are similar to extra pearls of wisdom that are shared for this specific protocol for providers to consider. This general trauma assessment protocol is the part of the first tool that EMS providers will use when treating a single patient involved in a traumatic incident. This protocol is used in tandem with another protocol, which will help providers determine what hospital is appropriate based on a number of different criteria called the trauma field triage criteria. So the trauma field triage criteria, or the TFTC, is what providers will use to determine what facility is most appropriate for their trauma patients to be transported to based on specific criteria. This page is taken directly from the protocol manual, is placed here for providers to become familiar with what it looks like. There are two colors with that patients can be classified in, red or yellow. These two colors will be explained later on in the presentation, and we will spend the next few slides going in depth of what each one means, starting with red injury patterns. There are 9 injuries that will place a patient within the red injury pattern classification. They are any penetrating injury to the upper body or proximal extremities. This means the upper arm or leg. Skull deformity or suspected skull fracture. Suspected spinal injury with the new motor or sensory loss. Chest wall instability, deformity or suspected flail chest. Suspected pelvic fracture, suspected fracture of 2 or more proximal, so the upper leg or arm, long bones, a crushed, degloved, mangled, or postless extremity, amputation proximal, which means above to the wrist or ankle, and any active bleeding that requires a tourniquet or wound packing with continuous pressure. Key points to consider are the word suspected or proximal in several of these injuries. If a provider suspects fractures to specific areas of the body, medical directors want them to take due regard and have those patients transported to the highest level trauma center. In these situations, it's better to over than to underestimate the extent of these injuries because there could be significant internal trauma that providers may not easily observe. Proximal is the other keyword which indicates closer to the body. Though the patient may have a broken forearm and broken lower leg, these are both distal and the patient would not meet red criteria based on injury pattern alone. That brings us to the next box, which is red mental status and vital signs. Going back to the patient that had the broken forearm and lower leg, they may not meet criteria for injury patterns, but they could easily fit into one of the mental status or vital signs within the red criteria. If any patient is unable to follow commands, so a GCS motor score of less than 6, they have a respiratory rate less than 10 or greater than 29 breaths per minute, or are respiratory distress or need for respiratory support, and a room air sat of less than 90%. Those all classify patients into the red vital signs or mental status category. Other vital signs will be determined by the age of the patient. The main 2 factors will be the blood pressure or BP, or how the blood pressure compares to the heart rate or HR of the patient. The reason for the vital sign of the HR being greater than the systolic blood pressure, or SBP, is due to the shock index, which is being incorporated into traumatic injuries assessment for blood product administration. The shock index is calculated by heart rate divided by systolic blood pressure. To make it easier to understand, if the value is greater than 1, the patient has a significant reduction in blood flow and in dire need of blood products. For example, if the patient has a heart rate of 110 and a systolic blood pressure of 100, 110 divided by 100 equals 1.1, which means that the patient needs blood as soon as possible, which for us comes from Mercy Air. To make things even easier, if the heart rate is greater than the systolic blood pressure, call for flight and obtain IV access. Aim to maintain a systolic blood pressure above 90 for patients 10 to 64 and above 110 for any patient over 65, as the systolic blood pressure below that is red criteria. Minimal acceptable systolic blood pressure for 0 to 9 years of age can be calculated with the formula 70 plus 2 times their age in years. If you have a 6-year-old with a traumatic mechanism, their minimum systolic blood pressure would be 82, because that is 70 plus 2 times 6, which is 70 plus 12, which equals 82. Any systolic blood pressure less than that would meet red criteria. Any red criteria will deal with either injury or injuries that the patient has or their mental status and vital signs. The mechanism of injury, or MOI, will place patients into the yellow criteria. There are 4 major criteria, which are high risk auto crash, a rider separated from the transport vehicle with significant impact, be it if they were riding a horse, motorcycle, ATV, or etc. A pedestrian or bicyclist rider thrown, run over, or hit with significant impact, or a fall from a height of greater than 10 feet, regardless of age. Many providers will cite old protocols that state that a fall is 2 times the height of the child for a pediatric patient, but that has since been removed. Returning to the high risk auto crash, there are several definitive criteria. These are partial or complete ejection, significant intrusion, including the roof, which is defined as greater than 12 inches on an occupant site or greater than 18 inches on any site, or if there is need for extrication for an entrapped patient. If there is death in the passenger compartment, or a child 0 to 9 that is unrestrained or in an unsecured safety seat, or if the telemetry data is consistent with severe injury, are other definitive criteria for high risk auto crash. It is important to note that these are instances where other responders may say that the patient meets red criteria based on the MOI, which is not the case. As we just learned, red criteria only deals with the injury itself or the mental status and vital signs of the patient. Though the MOI may be significant, stay calm and use good judgment on where the best destination is for your patient. The last section of our yellow criteria deals with EMS judgment. The patient may not meet any of the aforementioned criteria, but responders may still have that tingle in the back of their mind that something is off. If you are concerned, have the patient transported to a trauma center. They may not meet any criteria in the previous 3 categories, but you can still have the patient transported to a trauma center. Some judgment criteria is low-level falls for children or older adults with suspected head injury, and those children are 5 years or less. Anticoagulant or anti-placement use, which are blood thinners, suspected child abuse, special or high resource healthcare needs, or a pregnant patient that is greater than 20 weeks gestation. Remember that if you're responding to an incident that is traumatic in nature, consider traumatic injuries before medical problems. It may be a medical issue that caused the traumatic mechanism, but we want you to treat any obvious trauma or life threats before moving on to medical problems. If at any time you don't feel comfortable with having the patient go to a normal hospital, request them to be taken to a trauma center. Now that we understand what constitutes red or yellow criteria, we will discuss what that criteria dictates when determining where the patient should be transported. This is the second page of the TFTC that can be found in the protocols. Each color has specific trauma centers that patients can be transported to. This will be covered in detail in the next slides. Patients that meet red criteria can be transported to UMC or Sunrise based on geographic location. For our district, all patients that meet red criteria will be transported to UMC. Patients that meet yellow criteria may be transported to other trauma facilities. For our district, our patients that meet yellow criteria for MOI may be transported to UMC or to the military base hospital, which is Mike O'Callahan Military Center. If the patient meets any red criteria or the provider feels that their specific needs that the MOMMC, again, Mike O'Callahan Military Center, cannot meet, have the patient transported to UMC. If the patient meets yellow EMS judgment criteria, they may be transported to those same trauma centers, but they may also be taken to any other appropriate facility. This means that if a patient wants to be transported to a facility that is not a trauma center, but can still provide appropriate care, they are allowed to be transported to that facility. There are a couple key points in the additional notes that impact where our patient will be transported. The first note is one of these that states that any patient, regardless of location, that is transported by air ambulance is to be transported to UMC, and medical direction must come from that center. This means that if you want to put your patient on flight, they must go to UMC regardless of your location. If you want to request any orders for that patient, they must come from the trauma doctor at UMC. There are two caveats to this point, with the first being that if the provider's judgment, the time to transport to the designated center would unduly prolong due to traffic or weather conditions and might jeopardize the patient's condition. This caveat could impact our district if there's inclement weather in Las Vegas that prevents Mercy Air from flying there, and they would have to divert to Dixie, which is a level 2 trauma center. So an important detail to note is that UMC is the only level 1 trauma center, which means they are a teaching hospital and have surgical teams and or specialists on site 24/7 to trauma. A level 2 trauma center such as Dixie or Sunrise does not have those teams or specialists on site 24/7, but has them on call during certain times of the day. So the second caveat is that if, in the provider's judgment, the ability to adequately ventilate the patient might result in increased patient mortality, the patient can be transported to the closest facility. Other notes are to consider if the trauma center is on internal disaster to bypass them, and if the patient or guardian of the patient refuses transport to the closest appropriate trauma center when they meet criteria, they must sign a release of medical assistance or an AMA acknowledging their refusal. They can still be transported by ambulance to the facility of their choice, but they still have to sign the AMA since they meet criteria for a trauma center but refuse to be transported there. These protocols are what EMS providers will use when treating and determining the destination for a single patient. When there's an incident with multiple patients, however, EMS providers will have to use other means to determine the severity of the patients on scene. This section of the flowchart shows the expectations for EMS providers when there are multiple patients in a vehicle accident. The first step after it has been determined there are multiple patients is to begin triage. There are several methods providers can use, but the main one we will focus on is the simple triage and rapid treatment or START method, which uses the 32 can do or RPM acronym. The flowchart for this method is on the next slide. So here are two different flowcharts of the same START triage method. Both will be supplied so providers could choose whichever is more visually pleasing for them. In either case, the process, colors, and terminology are the same. Patients will fall into one of 4 categories with their corresponding colors. Walking wounded equals green, delayed equals yellow, immediate equals red, and expected equals black. The picture on the right gives some more detailed description on what each classification entails, while the picture on the left shows the 32 can do and the respirations, perfusion, and mental status or RPM acronym. The basics of triage are as follows. Can the patient walk and follow directions? Have those patients walk to you and out of the way. These patients will initially be triaged as green. R, or 30, is the patient breathing or have spontaneous respirations? If not, position the airway. If the patient is still not breathing, that patient is initially triaged as black, which means they are expectant, and the EMS providers will move on to the next patient. If they are breathing after you manipulate the airway or their respirations are greater than 30 per minute, or repositioning the airway creates spontaneous respirations, that patient is initially triaged as red, which means they are immediate and will need treatment and transport first. If their respirations are less than 30 in a minute, the EMS provider will move to P or 2. So the next step in triage is to feel for radial pulse and check cap refill. If a radial pulse is present or the cap refill is less than 2 seconds, that provider can move on to the next step of triage of M or can do. If there's no radial pulse present or the cap fill is greater than 2 seconds, the provider should control major bleeding and that patient will be triaged as red. M or can do after the provider has determined that the patient's respiration are under 30, they have a radial pulse, or the CAT refill is under 2 seconds, they can assess the patient's mental status. This is as simple as, can the patient follow simple commands such as raise your arm, blink your eyes, wiggle your toes, etc. If they can, that is the only time a patient will be initially triaged as yellow, which means that the treatment or transport for this patient can be delayed until after patients with life-threatening issues are treated. If the patient cannot follow simple commands, they are triaged as red. A last note on triage is reference to the chart on the right. There is other information that providers can use when performing triage. Performing palliative care for any expectant patients, immediate patients will need treatment within 60 seconds to survive, whereas delays will not deteriorate for several hours. This type of triage is what will be used most often in MCI situations, unless there is a hostile MCI, which will not be covered in this presentation. Also not covered in this presentation is doing your XABCD or your March assessment for trauma patients. In each unit, there's an incident worksheet to assist the IC in either running a complex fire incident or to manage RIT or an MCI. The picture on the slide is from that worksheet and is referencing what information is needed to be given to the IC when it comes to triage. This chart will be filled out by the triage group supervisor, the medical group supervisor, or any member assigned by the IC to report the primary triage. As we covered how triage is to be accomplished in the previous slide, we will only mention here to make sure the total count of the patients that have been triaged match the total number of patients on scene. Though this seems obvious, patients can and have been missed on calls on several occasions. Triage is a broad part of what providers will do on large-scale incidents. The last part of the flow chart has to deal with access to the patients, especially if their triage is red. Though this is only on one side of the flow chart that has to deal with multiple patients, this process can be applied to the single patient also. Many critical patients may still be trapped within the vehicle. These patients will be difficult to not only get access to, but also to manage, as responders may have to get into the vehicle with the patient if they are able. With these patients, providers will have to work with crews on scene to assist in the extrication if the patient is trapped. That does not mean that they will be performing extrication firsthand, but they can determine the location of where the patient will be moved to once they are able to be moved from the vehicle. They may also help in extracting the patient from the vehicle so they can begin treatment as soon as possible. EMS providers play a significant role on vehicle accident scenes. They are the primary resource for not only the care of the victims, but also for performing triage for them, whether there is one or more patients. The primary concern for EMS on any scene is to first determine how many patients there are and then move to how critical the patient is. Providers may also have to determine resource needs when it comes to patient care, such as having the patient transported by air or by ground. The protocols that providers will utilize during these incidents may vary from the general trauma assessment to ventilation management. Though this presentation does not go in depth with many of the protocols providers will use, the protocols it does cover are vital to the outcome of the incident and the patient. Providers should be familiar with how patients are triaged using both the triage field criteria per the protocols and the START method. Both of these will guide providers on how to treat patients and where the patient should be transported. EMS providers should be well versed in not only the protocols they use to help treat patients, but also with their knowledge of how to identify certain injury patterns or illnesses that they may need to treat when they respond. Since most of our calls for response are for EMS providers, it is vital that they remain calm when responding to these calls for service and treat patients to the best of their ability.